Hello, I'm Dr. David Geller, Director of the UPMC Liver Cancer Center. It's a pleasure to have an update about our liver surgical oncology program. We've been collaborating with the Department of Radiology and specifically interventional radiology and abdominal imaging for the last 30 years. I've actually been here more than 30 years because I did a decade of training. At the Liver Cancer Center, we see over 500 new liver cancer patients a year, and we do aggressive surgery, especially minimally invasive liver surgery, but we also have about 400 patients a year that are not candidates for surgery, and then we work with our radiology colleagues for regional liver therapies. This includes chemoembolization as well as yttrium-90, and it's about 350 TACEs a year and 50 yttrium-90. This is really a unique program that's completely based upon collaboration, and every patient is presented at the liver tumor board weekly on Wednesdays at 3 o'clock, and we then decide what's the best approach for the patient, whether it's resection or ablation or regional therapy, and we also look for clinical trials. I can tell you that it's a great working relationship because Dr. Orens and Amersher and Novelli and I have been working together for at least 10 to 20 years, and I'm on the phone with 2 or 3 times a day with them talking about each patient that's on the table. We have up to 4 spots a day, 5 days a week, and we so much rely on our interventional radiology colleagues, not only for treatment strategy, but also for regional therapy. The patients are admitted as a one-stop shop to the liver cancer program, and they're managed jointly and in inpatient and outpatient basis, and we find this really gives state-of-the-art multidisciplinary care for patients with primary and metastatic liver cancers. The diseases we treat are hepatocellular carcinoma, cholangiocarcinoma, metastatic colorectal cancer, and metastatic neuroendocrine tumors to the liver. The integrated program also involves very closely our gastroenterology and hepatology colleagues, the Starzl Transplant Institute, as well as our medical oncologists from the UPMC Hillman Cancer Center. So really, the patients get about 5 teams discussing their case each week and coming up with a strategy. This really is a streamlined service where everybody's working on the same team and there's no internal competition, if you will, for patients, but rather we all work together to give the ideal care for the patient. And so we think that the University of Pittsburgh Medical Center is a great place for surgical and radiology training, as well as for advanced fellowships, because we see some of the most complex cases in the country. And I look forward to working with you and your radiology mentors in the future. Thank you.
I'm Ray Sakula. I'm a neurosurgeon at the University of Pittsburgh Medical Center. I've been here since 2013. My specific charge is in the area of cranial neuralgias and skull-based disorders. And I work very closely with a number of neuroradiologists here. My colleagues in all the other disciplines such as neurovascular surgery, spinal surgery, skull-based disorders, functional disorders also work very closely with our radiology colleagues here. I think it's a unique relationship. We're always back and forth between each other's conferences and the reading room, which I'm standing right outside of. And I think it's just a terrific relationship that's developed long before I arrived, but it certainly persists.
My name is Brian Zuckerberg. I'm one of the general and trauma surgeons. I came to Pittsburgh originally in 1997 to do my residency in general surgery and have been here ever since. I love the city, I love the working environment, and as far as our relationship with radiology, it's been a wonderful, collaborative, supportive relationship throughout. I learned a ton as a resident. I continue to learn a lot, and we really depend upon each other in the care of our trauma patients, both from a diagnostic radiology standpoint, interventional radiology standpoint, and it's a wonderful place to be.
I'm Dr. Rockell Ford. I'm the Trauma Medical Director here at Presbyterian Hospital, which means I oversee the trauma service. I'm also an acute care surgeon and work in our trauma ICU. As the Trauma Medical Director, I'm responsible for overseeing the care of approximately 4,500 trauma admissions a year here at Presbyterian Hospital. We're the busiest trauma center in the state of Pennsylvania, and all of those trauma patients end up with multiple different radiologic studies. So plain films, CT scans. We are incredibly dependent on the collaborative relationship between the trauma service and our radiologists, both in terms of diagnostic radiologists, in terms of reading scans. We are incredibly grateful that we are able to get reads of CT scans 24 hours a day for our acutely injured patients. And then many of our patients end up requiring interventions in interventional radiology. And so we have a fantastic collaborative relationship where I will frequently call up our interventional radiology colleagues in the middle of the night or on weekends or holidays and talk through a complicated patient to make sure that we are creating a coordinated management plan. As radiology residents, we will interact with you guys in the reading rooms. We look at all of our own images, and we will sometimes come down to the reading room to look at them with you if there's something that's interesting or different or that we're not sure about, because we want to be looking at these studies ourselves. But also we have a rotation on our acute care surgery service where preliminary residents going into radiology may come and rotate on our acute care surgery service. And it's a great opportunity for us to tell you why we're ordering the things we're ordering, what we're ordering, and look at the images with you so that you can see from the surgeon's eye what we're looking for when we get these studies. I couldn't do my job without my colleagues in radiology, both diagnostic radiology and interventional radiology.
My name is Abhi Humar, and I'm the clinical director of the Starzl Transplant Institute here at University of Pittsburgh Medical Center. The Transplant Institute here is one of the oldest and one of the first transplant programs established in this country, first established by Dr. Thomas E. Starzl, who's the namesake for our program, and who many regard as the father of modern-day transplantation. Established more than 35 years ago, at that time the transplant program represented the mecca of transplantation. It was the place where patients from all around the world came for transplants, as well as physicians of all specialties came to learn about the craft of transplantation. Fast forward now to 35 years, and transplantation is an established mainstream form of therapy for mostly all patients with end-stage organ disease. But nonetheless, we remain at the forefront of transplantation here at University of Pittsburgh Medical Center, with strong programs and comprehensive programs in all of the various aspects of transplantation. We have strong lung as well as heart transplant programs, and the Starzl Transplant Institute encompasses all the abdominal organ transplants, which includes liver, kidney, pancreas, intestine, multivisceral, as well as islet cell transplantation. As I said, we are a very comprehensive program, meaning we have specialty in areas of just about every aspect of transplantation, which includes both adult as well as pediatric transplantation, and transplantation from deceased donors as well as living donors. In fact, at the present time, we're the national leaders in live donor liver transplantations, and the majority, and in fact the largest number of live donor liver transplantations done in the United States are done here at UPMC. As you can imagine, a large team such as this requires a multidisciplinary collaborative approach, and we work with many disciplines across the different specialties as part of the transplant program. Integral part of this is our partnerships with our radiology colleagues, not only for the preoperative workup and the diagnostics that are so essential in all of these patients, but as well for the post-op management and long-term care of these patients, the management of complications that can happen, the screening that these patients require, the monitoring for ongoing issues such as rejection and various other things. And so, because of this, as I said, we have a very strong multidisciplinary approach and work very closely with our colleagues, including our radiology colleagues, to establish a top-notch program for all of our patients.